Hello, today we are going to discuss about Hodgkin lymphoma. Now, first of all, before discussing the Hodgkin lymphoma, first of all, a general idea regarding what lymphoma is all about. So, as we have previously discussed in the initial podcast about acute leukemias and chronic leukemias, we had said that lymphomas are basically malignancies of lymphocytes, that is, the malignancies of B cells or T cells, and it often involves the lymph nodes. So, malignancy of lymphocytes in the lymph node will be known as lymphomas. But lymphomas can also occur in the extranodal side like skin or GI tract. But generally speaking, the malignancies of lymphocytes within the lymph nodes is known as lymphoma. So usually what happens with the signs and symptoms of lymphoma are usually enlarged painless lymph nodes are found. In contrast to a reactive lymph node, which is usually swollen and painful, the lymph node in the lymphoma is enlarged and painless. That's the important point to consider as compared to reactive lymph node, which is usually painful. So then, apart from this physical finding, there is also another symptoms which are known as B symptoms, like fever, chills, and night sweats can also occur in the lymphomas. So, how we will differentiate the lymphoma categories, because there are two broad classifications of lymphoma. One is the Hodgkin lymphoma and the other one is the non-Hodgkin lymphoma. So we will talk in a minute that how we will differentiate between Hodgkin lymphoma and its another part which is known as non-Hodgkin lymphoma. So if we are seeing a painless lymphadenopathy, like painless enlargement of the lymph node, what we have to do is to do the tissue biopsy. So in the tissue biopsy we are seeing malignant lymphocytes like as expected in the lymphomas. So when within those malignant lymphocytes, if there are Reed-Sternberg cell on microscopy, we will say that it is Hodgkin lymphoma. And if the Reed-Sternberg cells are absent, we will say it's a non-Hodgkin lymphoma. So the other question emerges out that what is Reed-Sternberg cells? So Reed-Sternberg cells are basically a larger cell, multi-lobe nucleus, like it is having a multi-lobe nucleus. Basically it means that it is having two halves and often a mirror image of each other, and it is also known as owl's eye. So what is Reed-Sternberg cell? Within the lymphocytes you will find out that there are certain large cells with multi-lobe nucleus, often a mirror image of each other two halves, and it is having that appearance classically called owl-eyed. And it's usually derived from the B cells, not from the T cells. So usually most commonly the Reed-Sternberg cells are derived from the B cells, and they are usually having CD15 and CD30 markers. Usually having CD15 and CD30 markers, and it doesn't possess the classical B cell markers like CD19, 20, 21 and 22. So it's peculiar CD15 and CD30, but derived from the B cells, having multi-lobe nucleus, and it's a large cell. That's what Reed-Sternberg cells are all about. So when they are present in the microscopy, we will say that it's a Hodgkin lymphoma. And if these cells are not found, we will say that it's non-Hodgkin lymphoma. So the malignant cell is a Reed-Sternberg cell, but the point to be noted in this Hodgkin lymphoma is that Reed-Sternberg cells are basically a minority of cells in the enlarged lymph nodes, maybe like 1 to 5% of all the malignant cells. Like its ratio is really less as compared to the other cells which are present in that lymphoma, Hodgkin lymphoma, and the other cells usually are reactive cells. Why? Because Reed-Sternberg cell release cytokines, and within the cytokines are released, so it generates reactive cells, and a majority of the cells in the lymph node are reactive and minority are the Reed-Sternberg cells. So that's why due to release of cytokines, these symptoms are more common in Hodgkin lymphoma as compared to non-Hodgkin lymphoma. And the other point worth mentioning is the formation of high calcium, like hypercalcemia is also found in Hodgkin lymphoma as compared to non-Hodgkin lymphoma, because one of the reactive cells is the macrophages which are found, and it starts synthesizing 125 dihydroxyvitamin D because it possesses that 1 alpha hydroxylase enzyme, and it will convert 25 hydroxy vitamin D to 125 hydroxyvitamin D. So commonly Hodgkin lymphoma presents with cervical lymphadenopathy with the presence of B symptoms, and its spread is a very predictable manner, and the stage is the strongest predictor of its prognosis. Another point worth mentioning is about the age distribution in the Hodgkin lymphoma. So the term bimodal age distribution is related with the Hodgkin lymphoma because it usually peaks either at age 60 or at age 65. So you can expect both in young as well as in old people. The risk factors of Hodgkin lymphoma are prior Epstein-Barr virus infections because these viruses usually infect the B cells. Immunosuppression state can also give rise to the Hodgkin lymphoma immunosuppression state like HIV, transplant, and then in certain autoimmune diseases like rheumatoid arthritis, systemic lupus erythematosus, Hodgkin lymphoma can also occur. So usually this lymphoma, Hodgkin lymphoma, is usually treated with chemotherapy and radiation therapy. So we have classified lymphoma by saying that it's either Hodgkin lymphoma when there is a presence of Reed-Sternberg cell versus non-Hodgkin lymphoma without the presence of Reed-Sternberg cell. Now let us further divide the Hodgkin lymphoma. So Hodgkin lymphoma has usually different patterns. One of it is the classical pattern and the other one is a rare entity nodular lymphocyte predominant pattern. Then the classical pattern, in which there is a cellular background, is further subdivided into 4 different categories, and one of that is nodular sclerosing, the other one is mixed cellularity, the third one is lymphocyte rich, and fourth is the lymphocyte depleted. So I would reiterate again that Hodgkin lymphoma can be divided into 2 different entities. One of it is a classical with a cellular background, and the other one is the nodular lymphocyte predominant pattern. Then the classical cellular background is divided into 4 different categories. One of it is nodular sclerosing, second is mixed cellularity, third is lymphocyte rich, and fourth is lymphocyte depleted. Now we will discuss the rare variant of Hodgkin lymphoma first, which is the lymphocyte predominant, or you can also say nodular lymphocyte predominant variant of Hodgkin lymphoma. So it is also sometimes called the popcorn cells, and usually it lacks CD15 and CD30 but expresses only important surface marker which is CD20. So like we had said previously that CD15 and CD30 are present in majority of the Reed-Sternberg cell, but in this lymphocyte predominant state of the Hodgkin lymphoma, the cells are usually possessing only CD20. So nodular sclerosing, now coming towards the classical Hodgkin lymphoma, the first one which we had said was a nodular sclerosing pattern, which is the most common type of Hodgkin lymphoma. Almost in 60 to 80% of cases of Hodgkin lymphoma, nodular sclerosing pattern is found, and it is more common in women as compared to men, and usually presents with mediastinal mass on chest X-ray. So Reed-Sternberg cells will be seen but in a clear space, and it is also called lacunar variant. It will grow slowly in the indolent pattern, and it is having usually good long-term overall survival. So the second classical Hodgkin lymphoma pattern is having the mixed cellularity. You will find out Reed-Sternberg cells intermixed with eosinophils, neutrophils, macrophages, and plasma cell. Then there is the lymphocyte rich pattern, which shows the excellent prognosis, and the fourth one is the lymphocyte depleted, which is having a poor prognosis. So, generally subdividing the Hodgkin and non-Hodgkin lymphoma, non-Hodgkin lymphoma we will discuss in the next podcast. But just for the understanding that how we differentiate these two uh, clinically, so we had said, yeah, histologically we have said that Reed-Sternberg cells are found in the Hodgkin lymphoma and Reed-Sternberg cells are absent in the non-Hodgkin lymphoma. But clinically, Hodgkin lymphoma is usually often localized, but the non-Hodgkin lymphoma is having often multiple peripheral sites. Hodgkin lymphoma spreads in orderly fashion from node to node, but non-Hodgkin lymphoma can spread in a non-contagious ways. Extranodal involvement is rare in Hodgkin lymphoma. However, in non-Hodgkin lymphoma, you can always found extranodal involvement, which is most common, just like involvement of the GI tract, involvement of the skin. So the treatment regimens are different in Hodgkin lymphoma, but one of the most classically uh, treatment regimen which is given, it is called ABVD. A stands for adriamycin, also known as doxorubicin. It's a cytotoxic antibody. The other is the bleomycin. From B, bleomycin, which is a cytotoxic antibody. V stands for vinblastine, which is a microtubule inhibitor. And D stands for dacarbazine, which is alkylating agent. And this concludes our podcast about Hodgkin lymphoma.